Hello everyone. In our series of Docplexus KOL interviews, today we have with us Professor Chintamani. Professor Chintamani is an eminent name in the field of oncosurgery. He is the member president of Association of Surgeons of India and Association of Breast Surgeons of India and is currently associated with Vardhaman Mahavir Medical College and Safdarjung Hospital, New Delhi. He is also a passionate writer with many books and book chapters to his credit. Professor Chintamani, you have done immense work in breast surgery. What is the recent paradigm shift in the management of breast cancer surgery?
Well, to say the recent one would be not the fair way to approach it, but in the last decade, the management of breast cancer has changed completely to the tune of, now what was earlier considered an incurable kind of cancer is now considered curable. The sad part is the same thing is not replicated in the developing country, that is our country and Asian subcontinent. While in the West, they are treating images, we are treating lumps here. So the paradigm shift that has happened in the last few years is basically about becoming more and more conservative, preserving more and more organs rather than losing them. So the surgery is becoming less and less radical, or shall I use the word less and less mutilating, and more preserving. At the same time, the cancer care has improved and we have patients that live for as long as anybody else. So it's potentially a curable disease. So that's a huge shift in itself. The other paradigm shift that I observe personally as I see the change in the scenario around me is that, the breast cancer patients in India are much younger than their counterparts in the West. In the West, as the age increases, the incidence increases. While in our part of the world, we have two peaks. One is in 40s, the other one is in 60s. And we published that data. We actually studied it in our population. Now, this younger population that gets cancer gets a worse one. It's very aggressive. It tends to have, what is commonly called in the technical sense as triple negative breast cancer, which has poor outcome. It presents very advanced. And this is roughly what has changed. But the good part of the paradigm shift is that we are more and more aware of this cancer. It is the most common cancer of human race today and the second most common cancer in the country for women after cervix. I personally think it is more common than cervix, but this is what our registries say. And metros like Delhi, Bombay, Calcutta, they will be having more of breast cancer than cervical cancer.
So you have a lot of experience with breast conservation therapy. What type of assessment is done for this therapy and any particular criteria that the patient needs to fulfill?
Yes, that's a beautiful question. The point is, if you're looking at breast conservation surgery or breast conservation therapy, rightly put, because a lot of people confuse the two terms, it is not surgery alone. Therefore, it is therapy. So it actually includes chemotherapy, radiation, and also other therapies to conserve the breast. And it takes more effort to conserve than to ablate. To destroy something is easier than preserving it. Now, what is important is the mindset that has changed. And we are believing now that it is possible to conserve the breast and yet achieve an oncologically safe outcome. That is to save patients from dying of cancer and yet preserving the breasts. So what do? First thing, we tell the patient that it is possible. And that's a major part. And the most important person in this entire decision-making is the patient himself. You must put the patient in the center. And you need to tailor the therapy to the patient. And when we are trying to tailor it to the patient, we often tell the patient, look, it is possible to save your breast and also save you. Very often they ask you a question, if you save my breast, you're leaving a ticking time bomb inside, which may explode any time. And we try to explain to the patient, no, the outcome, now there's enough data to prove it, that after conservation, provided you've done a good job of it, the results are the same as with ablative surgery, which used to be mastectomy in the past. Having said it, one shouldn't be going overboard in trying to conserve the breast when it's oncologically not safe. So what do I do when I talk to a patient? I explain to the patient that it is possible for me to conserve your breast if it is an early breast cancer. Now, what do I mean by an early breast cancer? That is less than 2 to 3 centimeters for a layman, and roughly less than 5 centimeters would be fine for me. And nodes but no metastasis, the lump which is not fixed to chest wall or the skin, that is, it is early breast cancer. The first thing is this, we must understand that. It is possible to conserve breast even in locally advanced breast cancers, but after using chemotherapy to downstage it. By and large, it's a standard of care for early breast cancer. So I'll tell the patient this is the standard of care. This is the evidence that we can conserve. Then the patient is going to ask you, so what is the risk? The risk is there is a higher incidence of local recurrence, but the outcome is not different. They live the same years, the time they die is the same, so nothing changes. So she will ask you a question, so what about this local recurrence? So the answer is, we can again excise it. So patient needs to be told that it may mean doing more surgeries than one. Many don't buy it, many don't accept it. Second thing which is mandatory is that patients should have a good tumor-breast ratio, because the whole idea of doing breast conservation surgery is to have a good cosmetic outcome, otherwise why do it? Secondly, the patient has to know that she'll be in constant follow-up, the center has to be close to her place or she should be close to that place, either way. Thirdly, she will require chemotherapy, she'll require radiation and prolonged treatment. If she is willing for all this and she is fitting into the criteria, then we offer breast conservation surgery. But you must explain to the patient, because sometimes what happens is, especially on media, it can go viral that you can conserve every breast. Today, it's not possible. It depends on the stage. When you're reading the literature, which is Western-based, you should be very careful that the cancers that are detected in the West are based on screening. So when you screen, you are picking up images. And what do we get here? We get large tumors, we get lumps. So there is a difference. So we cannot find Western solutions to Indian problems. You need to find Indian solutions to Indian problems. So breast conservation, I do a lot of it. We have good outcome, we have good data. We presented it in most international conferences with a good outcome. So it is feasible to preserve, but with the rider that you explain to the patient, these are the problems. But it is possible.
Okay. Besides breast surgery, you have done a lot of work in thyroid surgery. So what is the best possible way to differentiate between a benign and a malignant thyroid nodule, and what are the referral conditions for this?
Well, if you ask me, that's one surgery I enjoy the most, actually. I've done it quite a bit, and thyroid cancers is the predominant area where I'm actually devoted mostly. Thyroid nodule in about 80% individuals is benign. So that's one problem, one issue killed. Now, of the 20% that you get, they're subjected to the same kind of assessment that you do for any suspected cancer, even breast. We call it triple assessment in breast, that is clinical examination, imaging, and FNAC or core-needle biopsy. In thyroid, it's just the same. So there will be features in history which will make me think it is cancer. What would be those features? It's a swelling in the neck, which is thyroid, that has suddenly started growing in size, so sudden growth. It was painless for all these years, suddenly became painful. It was moving freely, now it's got fixed. But a very important change is the voice, because it is sitting right on a nerve called recurrent laryngeal nerve, which is responsible for the voice. So if it involves that, you will have features of hoarseness of voice, which is a very strong feature suggestive of malignancy. Also, if there are neck nodes, I would suspect that there is malignancy, if it has gone onto the nodes. And then there are certain glands which are so obviously malignant that the diagnosis is written on the gland. They are hard, nodular, fixed glands. So the diagnosis sometimes is very easy to make. This is clinical. Then I would like to, all patients for breast and for thyroid, I image myself. We do ultrasound ourselves. So I don't rely on a radiologist who's a general radiologist. You can do it yourself, and I know what I'm looking for, so I'll be able to find it. Like if you get into this room and you don't know what you're looking for, you could be the best searching person in the world, but you won't find it. But I'll find it because I know what I want. Same thing in thyroid. I look for a nodule which doesn't have central necrosis. There is no loss of halo, which is capsule, and it has not gone out of the thyroid gland to call it benign. So my way of looking at it would be based on investigation. And finally, of course, like I said, I'll put in a needle. There will be an FNAC done, which will let me know whether it's cancer or not.
So what are the main points any surgeon should keep in mind for an optimum and safe thyroid surgery?
Well, the Main points, well, there are too many. So, first of all, the surgeon has to be trained into doing a safe thyroid surgery. Look, when I teach my students and residents and trainees and junior surgeons, or wherever I go in workshops and teach, and there are many of these videos available, and teaching videos. First thing is, any surgeon who is not trained into doing it should not do it. There is no point being a monkey with a knife, because then you would be causing more harm than good. And there's an old accepted norm that we practice in medicine. You would be aware of it. Primum non nocere. Above all, do no harm. If you don't know, don't do it. So that's one. Number two, it's a surgery which is highly specialized. There are, when I teach my students, I was saying, I'm just continuing with that. It's not about removing the thyroid gland. It's about preserving 4 or maybe 5 very important structures. External laryngeal nerve, which supplies the larynx for voice, pitch, timbre, quality. Very important for a singer and also for politicians. The other is a recurrent laryngeal nerve, which is responsible for the movements of the vocal cords. There are 2 on either side. That makes it 4 structures. And then there are 4 parathyroids, which need to be preserved. So I teach them, preserve these and remove everything else. Thyroid surgery is done. But having said that, it's an extremely difficult job, but can be learnt with training. If you're brought up well, if you trained well, it is also a very enjoyable surgery to do and to practice.
So tuberculosis is very prevalent in India. So what are the main symptoms and pointers to diagnose tuberculosis in breast and thyroid? And what is your advice about management of tuberculosis in these organs?
Well, tuberculosis of these 2 organs is not very common. Tuberculosis of thyroid, fortunately, is not common. We have published a series which is very rare. It was done in, I think, 2003 or 4. I don't remember. Where we had this, case that presented as thyroid abscess. I did hemithyroidectomy. It came out to be tuberculosis. So it was a histological surprise. So to say that, thyroid is truly blessed with a lot of iodine. So it doesn't get infected easily. Breast tuberculosis we are getting more often now. And the tragedy is it overlaps a condition which is different totally. That is idiopathic granulomatous mastitis, which is responding to steroids, and if you give steroids to tuberculosis patient, it can cause flaring up of tuberculosis. But your question was, how do you make a diagnosis? First of all, suspect it. The eyes will not see what the mind doesn't know. So even if I tell everything today, it won't work, because unless you know what to look for, you won't find it. A tuberculous patient will have systemic features. What are the systemic features of tuberculosis? Evening rise of temperature, constitutional symptoms, evening fever with loss of appetite, weight, night sweats, and a general contact of tuberculosis somewhere or past history of tuberculosis. In the breast, it will present with multiple sinuses, something that is not healing, or a breast abscess that is not resolving, or a patient with an HIV case, immunosuppressed patients. They also get tuberculosis very commonly, and that tuberculosis is usually multi-drug resistant, a bad one. Extrapulmonary tuberculosis, whenever it happens, it is usually suspicious of, we should suspect immunosuppression, patients on steroids, chemotherapy, etc., etc. So my suspicion would be based on clinical history, and in this subcontinent, tuberculosis can mimic everything, including pregnancy, which causes amenorrhea. There is ascites, it looks like pregnancy, and patient continues to think, pseudocyesis as they call it. You continue to think the patient is pregnant, but patient is not. So tuberculosis is something which can mimic every possible disease. So we make a diagnosis based on clinical suspicion, then getting the routine X-ray, chest and other investigations done. The other thing is, when you get the pus out, you need to culture it for AFP, which is not common to find. It's a tough nut to crack. So it's more of a diagnosis of exclusion. You treat it for something else and you found tuberculosis, and then you treat the patient with anti-tubercular drugs. Patient gets well. That's the beauty of it. So it's a curable, treatable condition.
So you have a very vast experience, a very vast clinical experience. Which was the most challenging case in your career?
Oh, well, sometimes, it's very difficult to name one, because I'm truly blessed to be actually doing surgery, and that too at a center where we get such a high volume that you are bound to stumble upon a rare case every day. I have been, how should I tell you? There was one case which is published, I think, long back. which has nothing to do with cancer, actually. It was with a knife inside to, and patient living for 8 years. And then cancer of the esophagus getting into the pericardium, which we had to resect along with en bloc resection. And then there's a lady that we have recently done. She had cancer of the oral cavity, floor of the mouth, and breast cancer at the same time. So I had to do the commando for the head and neck cancer and mastectomy for the breast, and then free flap reconstruction in the same sitting. So challenges, so that's a part of surgeon's life, and at the day I don't get it, I feel strange. So too very difficult to say one or two, but many. I think most of the time the challenge is to, I tell you one very simple thing for the benefit of all those who are listening and watching. The smartest way to command nature is to obey it. So if you just flow along the way the nature is doing, you are successful. It's like if you're trying to go against the tide, body is trying to heal itself. All you need to do is support it. So do not do anything counterproductive. So there are just too many cases which are challenging. A huge fungating neck mass which was sitting on carotid, bleeding actually. I had no choice but to take it up as an emergency. Breast case which had actually opened up and it was bleeding from all ends. So there are too many challenging cases. I won't say that others wouldn't have faced it, but we work in a setup where the poorest of the poor comes. And also the tertiary care center, we get referral cases from almost every part of the country. And in Delhi, they come from anywhere. So almost every day, there is a challenge.
Is there any advice you would like to give for surgical postgraduates who are interested in this field?
It's a beautiful field. When we went into oncology, most people were very negative about it because most patients used to die. Now there is a patient of breast cancer that is 22 years plus. We have cancer survivor group and we take their walk every day. My celebrities are these patients who have lived that long and they braved it. So I don't call them cancer survivors, I call them cancer conquerors. So when they live 20, 21 years and they come in the OPD, lots of residents watch it, that cancer patients can also live. When I was training, it was generally considered a very depressive field. To the extent that there was no MCH or super specialty course at that time for oncology, people just took that because of their interest, they got trained into it. Or their mentor was an oncosurgeon. So most of my students have gone for oncology for the same reason, perhaps. It's a very fascinating field, but demands a lot of physical, mental, and spiritual strength. I was adding that at the end because it's actually gone out of use. And the greatest support that you have and the greatest strength that you have in this field is that of compassion. If you're compassionate, you'll get back the energy from your patients only. It's a joy to watch oral cancer stage 3 plus, breast cancer stage 3 plus coming back alive 8 years, 10 years, 12 years down the line. And especially for the breast cancer, it's becoming so common. And the women are getting this cancer in a fertile age when they're useful to the society. They have a role to play in the family. It is a very important phase of their life. And we can really contribute by taking care of it. The future belongs to, if they're looking at the arithmetic of it, the future belongs to oncology because non-communicable diseases are on the rise.
So do you think an online platform like Docplexus can help update medical fraternity in the field of oncosurgery?
Now, I'm actually a little curious as to why it won't be, because this question shouldn't arise. Because anything and everything is online today. It's virtual reality. If you read your old scriptures, life is an illusion. And what you're living could be dream or reality, we don't know. Similarly, online, virtual reality is the way forward. I think this is the best way to expand your classroom. I'll be teaching 100 students here, but if you expand it, if it goes online, I could be teaching 100,000. Now, this really opens up an opportunity for the teacher and the taught. Anybody can just log in and watch. The important thing is to look at the content. The content has to I'm sure that is what you would be looking at also. It should be authentic, no hip shots. It should be true, evidence-based rather than eminence-based. One should be able to say something which is evidence-based. Now, it is evidence-based to say that early breast cancer should today be treated by breast conservation surgery. It is evidence-based to say that in axilla you can do sentinel node biopsy. It is evidence-based that you can conserve the breast. So that should be conveyed. And an inadequately or suboptimally done job can be more harmful than doing nothing. So actually the message that this online source can take to people and to everybody is that it is the way forward. There is actually no other way to move forward.
Thank you so much, sir, for your time today. Thank you.
It's a pleasure. Thank you.
To stay updated on our latest KOL videos and interviews, please follow us on Twitter, like us on our Facebook page and subscribe to our YouTube channel. Happy Docplexing!